Welcome to Topic 4, Part 3. In this screencast, we're going to talk about disorders of red blood cells, anemia and polycythemia. Here are the learning objectives for Part 1 of disorders of red blood cell. Red blood cells, or erythrocytes, are biconcave discs, and this provides a large surface area available for oxygen diffusion. Red blood cells have no nucleus or organelles. Instead, they're packed with hemoglobin. This allows for their primary function, transport of oxygen on the heme group. Hemoglobin is composed of 2 alpha and 2 beta chains, and each of these chains contains an iron-containing heme group that reversibly binds oxygen. Most of the body iron is found in the form of hemoglobin in red blood cells. This iron gets recycled from old red blood cells when they get broken down. About 15 to 30% is stored for later use. In the liver as ferritin, that's the main source, and then the rest in the bone marrow. Dietary sources of iron are going to help to maintain these stores. Hemoglobin synthesis is going to depend on the availability of iron for the synthesis of heme. Let's talk about red cell production and erythropoiesis. So the number of red blood cells in the blood normally remains constant. And this is reflecting a balance between the production and this destruction. If we have too few red blood cells, this leads to tissue hypoxia. If we have too many red blood cells, this can lead to an undesirable blood viscosity or thickness. Erythropoiesis refers to the production of red blood cells. red blood cells are produced in the red bone marrow, and they're going to depend on adequate supplies of iron, amino acids, and B vitamins. Now, this production of red blood cells is going to be stimulated by tissue hypoxia. So when we have less red blood cells, we're going to have lower tissue oxygen tension. This could also occur with altitude. And this is going to stimulate the kidneys to release erythropoietin. And erythropoietin is going to stimulate the bone marrow to cause increased production of red blood cells that then get released as reticulocytes into the blood. A reticulocyte is an immature red blood cell, and normally reticulocytes account for about 1% of all red blood cells. Now, if the reticulocyte count was increased much above that, that would be an indication that we have an increased rate of red blood cell production. What happens to red blood cells when they break down? So red blood cells last about 120 days, and then their membranes become weakened and damaged. Now remember, they don't have organelles, so they can't replace membrane lipids and proteins. So they eventually become weakened, and then they get broken down by macrophages in the spleen and the liver and the bone marrow. So hemoglobin is taken and iron gets recycled from the heme group, and it gets recycled to the bone marrow for reuse, or it gets stored in the liver to be used later. The rest of the heme group gets released into the blood as unconjugated or free bilirubin. Now, if we have large amounts of hemolysis or red blood cell production or destruction, then we would get large amounts of unconjugated bilirubin in the blood, and that would be a cause of jaundice. The globin part of hemoglobin also gets broken down into amino acids, and they can get reutilized. But let's go back to the bilirubin. So the free bilirubin from the heme goes to the liver, and then the liver conjugates this bilirubin and secretes the bilirubin into the bile, and then it can get excreted into the feces. Some of that will also go out in the urine. If we have liver failure, then we can have difficulty conjugating that bilirubin, and that can also be a cause of jaundice. We'll talk about these causes of jaundice when we get to Topic 8 much later, but for now, know that we can get jaundice if we have excessive amounts of this free unconjugated bilirubin due to excessive hemolysis or breakdown of red blood cells. So let's look at the diagnostic tests of red blood cell. Red blood cell count, this refers to the number of red blood cells in the blood. Morphology refers to the size, shape, uniformity, and how mature those cells are. Hemoglobin, the amount of hemoglobin per unit volume of blood, and this can give us an indication of the oxygen carrying capacity of the blood. Hematocrit is the volume or percentage of whole red blood cells in the whole blood. Reticulocytes is a measure of the percentage of reticulocytes out of the total red blood cells, and as I mentioned earlier, this is a measure of red blood cell production. The mean corpuscle volume is the size of the red blood cells, and they can be classified as normalcytic, normal size, microcytic, small size, or macrocytic, or enlarged size. And then the mean corpuscular hemoglobin concentration, this is the amount of hemoglobin in each cell. These can be defined as either nomochromic, so normal color, normal hemoglobin concentration, or hypochromic, and these are going to be more pale, decreased color with decreased hemoglobin content per cell. And then this just shows some of the normal values and their significance for these values. This comes from table 13.1 in your book. Okay, let's talk about anemia. Anemia refers to an abnormally low number of circulating red blood cells or level of hemoglobin or both. And this is going to result in a diminished oxygen carrying capacity of the blood. This can be caused by bleeding, in which we lose iron. Remember, most of the body's iron stores are found in hemoglobin in the red blood cells. Excessive hemolysis, that's destruction of red blood cells. A lack of essential nutrients for red blood cell production, such as amino acids and B vitamins, or bone marrow failure. The effects or manifestations of anemia are grouped into 3 categories. Those related to the reduction in the red cell indices in hemoglobin, so those are the values that we were just talking about. Manifestations related to impaired oxygen transport and their compensations. And then some anemias have specific signs that are related to that specific type of anemia. Let's talk about some of the effects of anemia. So we're going to see a reduction in red cell indices and hemoglobin. This figure here shows a reduction in hematocrit. So this is normal, about 45% hematocrit. That's percentage of red blood cells in whole blood. In anemia, we see that's reduced. And polycythemia, which we'll talk about later, we see that's increased. We can also see changes in morphology, size, mean corpuscular hemoglobin concentration in different types of anemia. For instance, in iron deficiency anemia, we see microcytic, hypochromic red blood cells. In megablastic anemia, we see enlarged red blood cells. They're going to have a high mean corpuscular volume. In sickle cell anemia, we'll see an abnormal shape of red blood cells. Let's talk about some of the manifestations of anemia. So manifestations of impaired oxygen transport and some of the compensations. We're going to see an increased respiratory rate. That's going to be a compensation to try and increase the amount of oxygen going into the blood. Pallor of skin, mucous membranes, conjunctiva, and nail beds. This is going to be due to peripheral vasoconstriction in an effort to redistribute the blood. Tachycardia is going to be a compensation in order to increase oxygen delivery by speeding up the rate at which blood is delivered to the tissues. We can see palpitations, and this can be due to increased plasma volume and cardiac output as an effort to try and just maintain cardiac output. Fatigue, weakness, and dyspnea. This is just going to be the result of a decreased oxygen carrying capacity of the blood. Inflamed digestive tract and degenerative changes in the hair and skin. This is going to be due to decreased regeneration of epithelial cells that are going to require that oxygen. Angina, which is chest pain, or congestive heart failure. This can be seen in severe anemia. And then specific types of anemia often are going to have additional signs and symptoms related to their specific pathologies. Okay, this brings us to part 2 of our learning objectives regarding disorders of red blood cells. Okay, let's talk about the causes of anemia. And here you're going to want to use the screencast as I'm talking and or the book to fill in some of the details. So I'm going to talk through them kind of slowly to help you get them all. So what are some of the main causes of anemia are blood loss, excessive hemolysis, and impaired red blood cell production. So blood loss, we can have acute blood loss with a loss of intravascular volume. So this is where we're going to lose a whole bunch of blood acutely. And this is going to cause anemia due to secondary dilution of red blood cell count, hematocrit, and hemoglobin. And this is going to be due to redistribution of fluid into the vascular compartment. And this is to try and maintain blood volume, but it's going to dilute the red blood cells. Chronic blood loss without the loss of intravascular volume. So we're losing a small amount of blood over time. This is going to cause iron deficiency anemia. And the reason for this is because we're just losing, remember, most of the iron is found in the red blood cells. And if we're chronically bleeding, we're losing the ability to recycle that iron. Some of the causes of chronic blood loss include GI bleeding, cancer, and menstrual disorders. Number 2, excessive hemolysis. So hemolysis means excessive destruction of red blood cells. And this can be associated with an incompatible transfusion, so a transfusion reaction, hemolytic disease of the newborn, and any disorders that can lead to fragile red blood cell membranes. And then number 3, impaired red blood cell production. This can be caused by decreased erythropoietin. This occurs with kidney diseases. As the kidney fail, they stop producing as much erythropoietin. So many patients with kidney failure have to take synthetic EPO. Number 2, bone marrow depression. This can occur with cancer therapy, chemotherapy, certain drugs, or radiation. And 3, inadequate dietary supplies of essential nutrients that are needed for red blood cell production, such as vitamin B12 and folic acid. So now let's talk about specific types of anemia. Iron deficiency anemia. This is the most common form of anemia. It is caused by a dietary intake of iron below minimum requirements during periods of increased demand, such as may occur during growth in children and adolescents, or with pregnancy and lactation. Number 2, chronic blood loss. Remember, we're losing small amounts of blood and thus iron. This can occur with peptic ulcers, intestinal polyps, hemorrhoids, cancer, or we could have impaired duodenal absorption of iron in some conditions such as maybe like Crohn's disease, or this could also occur with severe liver disease, which liver is damaged and we don't have as many stores as ferritin. What are the manifestations of iron deficiency anemia? Here again, I want you to use this screencast or the book to fill in the details. So size and color of red blood cells. These red blood cells are going to be microcytic, small in size, and hypochromic. So microcytic and hypochromic. And let's look at the blood results. For hemoglobin is going to be low. For hematocrit is going to be low. And then serum iron and ferritin levels are also going to be low. Some of the other manifestations that we're going to see are some of the general anemia signs of fatigue, lethargy, cold intolerance, irritability. You can also see epithelial atrophy, and that can lead to a waxy pallor, brittle hair, brittle nails, a smooth tongue. In some cases we have pica, and that's a craving for ice and dirt, I guess to get iron into the diet there. We can also have tachycardia, increased heart rate, heart palpitations, dyspnea, and syncope. Megablastic anemia. This type of anemia is characterized by enlarged and immature red blood cells due to impaired maturation and division. The MCV, the mean corpuscular volume, is greater than 100 femtoliters, and this is due to impaired maturation and division. These cells are immature, sometimes called megablasts, okay, and they often contain nuclei and other organelles. Remember, a normal red blood cell does not have these. In addition to the immature megablast cells, we also have immature white blood cells with hypersegmented neutrophils, as well as low thrombocytes. Now, one of the things that happens is these large and immature red blood cells have more flimsy membranes, and this causes the red blood cells to be destroyed prematurely, and this can lead to anemia and mild jaundice. Some of the causes include a vitamin B12 deficiency, including pernicious anemia, which we're going to talk about next, and a folic acid deficiency. So both of these can result in megablastic anemia. But let's talk about pernicious anemia. So pernicious anemia is caused by a vitamin B12 deficiency as a result of chronic gastritis and inadequate secretion of intrinsic factor. So let's take a look at our normal physiology. So parietal cells of the stomach, these are the same cells that secrete hydrochloric acid. They also secrete intrinsic factor. And in the stomach, intrinsic factor binds to vitamin B12 and it protects it and allows vitamin B12 to be absorbed in the ileum. So in order to get proper absorption of intrinsic factor, of B12, we have to have it complexed with intrinsic factor. So anyway, pernicious anemia is thought to be an immune disorder due to autoimmune destruction of the gastric mucosa. And this is marked by a loss of these parietal cells and production of antibodies. So that's going to interfere with binding of B12 to intrinsic factor. Other causes of vitamin B12 deficiency, but that are not specifically pernicious anemia, include removal of part of the stomach, resection of the ileum, inflammation, cancer of the ileum, we're reabsorbing here, but rarely dietary insufficiency is a cause. We have about a 7-year supply of vitamin B12 in our bodies already. Okay, so let's talk about some of the manifestations of pernicious anemia. Okay, so we're going to have the normal general anemia signs such as pallor and tachycardia. We also have glossitis, and that's where the tongue is typically enlarged, red, sore, and shiny. Digestive discomfort, often with anorexia and diarrhea. In part, remember, we're not secreting enough hydrochloric acid either, and that's going to contribute to some of the digestive problems. Abnormally large red blood cells, and this is going to cause an increase in the mean corpuscular volume, but with a normal mean corpuscular hemoglobin concentration. Mild jaundice, because the red blood cells are destroyed prematurely. B12 serum levels are going to be below normal. We can see the presence of hypochlorhydria or achlorhydria. That's a reduced amount of hydrochloric acid, and that's because the parietal cells secrete both intrinsic factor and hydrochloric acid. And then we can also see neurological symptoms. This is kind of a special sign and symptom related to vitamin B12 deficiency. So these neurological symptoms are related to demyelination of the dorsal and lateral columns of the spinal cord. So this can cause things like the feeling of pins and needles, tingling in the limbs, loss of vibration and positional sense, and eventually can lead to spastic ataxia. Aplastic anemia is due to impairment or failure of the bone marrow. This can be temporary or it may be permanent. It's often idiopathic, but other causes include myelotoxins. These are things that are toxic to the bone marrow, such as chemotherapy and radiation. Viruses, including hepatitis C, and genetic abnormalities. The blood counts indicate pancytopenia, which means anemia, leukopenia, and thrombocytopenia. Because we have suppression of the bone marrow, all formed elements are going to be reduced. In addition to general anemia signs, these patients can also have bleeding and recurrent infections because of the suppressed thrombocytes and leukocytes. So these patients are at risk of death from uncontrollable infection and hemorrhage due to the lack of white blood cells and platelets. Okay, next we have hemolytic anemias, and this results from excessive destruction of red blood cells. There are a variety of causes. There are some genetic disorders, such as sickle cell anemia and thalassemia, immune reactions that attack the red blood cells, infections such as malaria, various toxins in the blood, and then antigen-antibody reactions, such as occurs with an incompatible blood transfusion or with erythroblastosis fetalis, or hemolytic disease of the newborn. Sickle cell anemia is a genetic disorder which results in recessive inheritance of DNA that results in the mutation of one amino acid of the beta chains of hemoglobin, resulting in hemoglobin S instead of hemoglobin B. This should say B here. If you have the sickle cell trait, you're a heterozygous, so you have one normal gene and one defective gene. And in this case, about 40% of your hemoglobin beta becomes hemoglobin S. With sickle cell disease, you're homozygote, and you have 80 to 95% of your hemoglobin B is in the form of hemoglobin S, or has this mutation. This mutation provides some protection against malaria. So if you have the sickle cell trait, you actually don't have the disorder, but you have protection against malaria. If you have sickle cell disease, you do have the disorder. So what happens? So when the red blood cells that have the hemoglobin S are exposed to low oxygen tension, they sickle. They become sickle shaped. At first, this is reversible, and when they get reoxygenated, they can resume normal shape. But over time, they become irreversibly sickled, and this can cause them to have a difficulty passing through the microcirculation, and that can lead to premature destruction or hemolysis, blockage of the vessels, and tissue ischemia and infarction. So sickled cells block capillaries, and this can lead to acute pain. This can cause infarctions, leading to chronic damage to the liver, to the spleen, to the heart, to the kidneys, to the eyes, to the bones. Also, the sickled cells are more likely to become destroyed prematurely. They last about 20 days instead of 120 days, and this is going to result in jaundice and severe anemia. A sickling crisis is going to be precipitated by hypoxia, as well as dehydration, acidosis, cold, stress, and physical exertion. Okay, so let's talk about some of the manifestations and complications. So severe hemolytic anemia is going to result in hyperbilirubinemia, so high bilirubin in the blood, and jaundice, and vaso-occlusive crises, so where we're blocking blood vessels, and this can cause acute pain due to tissue hypoxia, especially in the chest, abdomen, bones, and joints. Chronic damage to the liver, spleen, heart, kidneys, and retinas. Acute chest syndrome, which is an atypical pneumonia due to pulmonary infarction, and that can lead to chronic respiratory insufficiency and death. This can also cause stroke and blindness. Splenomegaly, swollen spleen, injury and life-threatening illnesses, and growth retardation in children. Now, fetal hemoglobin has no beta chains, so they can't sickle. So the clinical signs do not usually appear until the child is about 12 months of age. So fetal hemoglobin with the alpha chains and gamma chains, but no beta chains. So that means that those fetal cells can't sickle. But over time, the gamma chains are replaced with the mutated beta chains, then they start to sickle. So persons with some fetal hemoglobin are partially protected from sickle cell disease. Okay, next let's talk about hemolytic disease of the newborn. Hemolytic disease of the newborn occurs when we have a sensitized Rh negative mother who is pregnant with an Rh positive baby. So let's review our normal Rh antigen. So with the Rh blood group, if you are Rh negative, you don't have the antigen. If you are Rh positive, you do have the antigen. So if you don't have the antigen and you are exposed to the antigen, then you will make antibodies against that antigen. That's called sensitization. So unlike the ABO system in which you are naturally exposed to substances that are like the A or B antigen if you don't have them, the Rh antigen, you can only be exposed to it with a transfusion with a Rh positive blood or with a previous pregnancy with an Rh positive baby. Okay, so once again, this can only occur with an Rh negative mother who's been sensitized by prior exposure to the Rh antigen, either from a transfusion with Rh positive blood or from a previous pregnancy with an Rh positive baby. Now, if the mother is Rh positive, she's not going to make the antibodies against the Rh antigen because she has the antigen. So it's going to require an Rh negative mother with an Rh positive baby. So let's talk about how this occurs. So her first exposure occurs with the birth of the first Rh positive infant or transfusion. Okay, so during birth, when the placenta tears away from the uterus, some of those fetal red blood cells can leak into the maternal blood, and that's going to cause the mother to become sensitized and to produce antibodies against the Rh antigen. Now the first baby's okay because the mother, their blood supplies are separate. Antibodies can go across, but if she hasn't already been exposed to the antigen, then they can't attack the baby. But at birth, once the placenta rips away, then some of those red blood cells can escape into her circulation. Then she becomes sensitized. She produces antibodies. So then the second exposure to an Rh positive fetus, these small antibodies can cross the placenta and can attack the embryonic fetal red blood cells. So what do they do for these babies? What do they do for these mothers? So what they do is they give RhoGAM, and RhoGAM is actually Rh gamma globulins or antibodies. Now at first this doesn't make sense. Like, why would you want to give her antibodies? Well, you do this at about 6 months of pregnancy and after delivery of her first and subsequent babies. And the point of this is if any of the fetal red blood cells escape into the mother's circulation, those antibodies will mask them and cause destruction, ultimately, of the red blood cells, the baby's red blood cells, in the mother before the mother's circulation, or before the mother has a chance to become sensitized. So that's the purpose of RhoGAM. Okay, and our last topic on red blood cells is polycythemia. And polycythemia is when we have excessive red blood cells that are going to increase the blood viscosity or thickness. So this is going to result in an increased hematocrit of greater than about 54% in males, greater than 51% in females. So we have relative polycythemia and absolute polycythemia. So relative polycythemia is not a true increase in red blood cell. Rather, this is due to a loss of plasma volume. So for instance, we have relative polycythemia in dehydration. So we lose plasma volume, but not actually red blood cells. But our hematocrit is high because we have less plasma volume. Number 2 is absolute polycythemia. So this is a true rise in hematocrit due to an increased rise in the total red blood cell number. This can be caused by polycythemia vera. This is a primary disorder. It is a neoplastic or cancerous disorder. It's serious and can be life-threatening. Or secondary polycythemia, and this is a compensation for low oxygen. For instance, that low oxygen can be caused by either going to high altitude or by respiratory illnesses, and this is rarely life-threatening. So let's talk about the manifestations related to polycythemia. We can have distended blood vessels and sluggish blood flow, okay, because that blood is really thick. High blood pressure due to the increased viscosity, and that's going to result in a bounding pulse. Hypertrophied heart, because the heart's going to have to work harder to pump that viscous blood. Swollen liver, swollen spleen, shortness of breath, headaches and visual disturbances, increased amount of thromboses or blood clots and infarctions, a plethoric and cyanotic appearance. So part of the reason for the cyanosis is because, and that's the bluish discoloring of the skin and mucous membranes, is because we have so many red blood cells that we're going to have more hemoglobin that is not bound to oxygen. So we can have decreased, a lower percentage of oxygen hemoglobin saturation because we just have so many red blood cells. And also because the blood is moving so slowly, then it's and it's so thick, it's not getting to the extremities as well. So we're going to see increased cell counts, increased hemoglobin, increased hematocrit, increased uric acid in the blood due to the breakdown of red blood cells. Treatment is going to be aimed at identifying the cause, maybe drugs or radiation to suppress the bone marrow. And here's where that leech therapy actually may have been helpful. We can give periodic phlebotomy. We can remove some of the blood from the patient. Okay, before I leave polycythemia, let me go back and talk about the primary versus secondary. So with primary, this is one of your case studies too. So with primary polycythemia, because this is a neoplastic disorder, if we have uncontrollable proliferation within the bone marrow. So because we have so many red blood cells, our EPO level, okay, so our oxygen levels are pretty good. And this is going to cause our EPO levels to be low, right? Because there's not that response. We have so many red blood cells. In secondary polycythemia, because this is a compensation for low oxygen, that polycythemia is induced by the hypoxia. So the hypoxia is going to cause an increased secretion of erythropoietin, and that erythropoietin is going to stimulate red blood cell production. And this is as trying to compensate for the decreased oxygen due to altitude or respiratory illness. Okay, so you should look at the concept check questions and make sure you can answer those, and then we'll go ahead and look at a few other questions here. So why would a man receiving chemotherapy for cancer develop anemia? Okay, so he's going to develop anemia because the chemotherapy is suppressive to the bone marrow. And so this could result in like an aplastic anemia, reduction in red blood cells, white blood cells, and platelets. Why would a man with renal failure develop anemia? Okay, this fellow is going to develop anemia because in kidney failure, we're going to have decreased production of erythropoietin, and erythropoietin is the hormone that stimulates red blood cell production. Why would a man with liver failure develop jaundice? He would develop jaundice because the liver processes the bilirubin, and even if normal amounts of bilirubin are produced, if the liver is failing, it can't keep up. Why would a man with defective red blood cells develop hepatosplenomegaly? If he has defective red blood cells, that's going to result in excessive hemolysis, and that's going to cause the liver and the spleen to have a bunch of broken down red blood cells that they need to process, and that's going to result in them being swollen. Okay, a scenario. A boy presents with pallor, weakness, increased respiratory and heart rate, enlarged spleen and liver, yellow skin, dark brown urine, and a low red blood cell count. So first question, does he have a deficiency or a hemolytic anemia? Okay, if we look at this, we see that he has enlarged spleen and liver, yellow skin, dark brown urine. So that's going to suggest, because he has jaundice, that's going to suggest a hemolytic anemia. Next question, which symptoms are caused by a decreased red blood cell count and hypoxia? Well, pallor, weakness, increased respiratory, and heart rate are going to be caused by those, and a low blood cell count. What's going to be caused, or what symptoms are going to be caused by hemolysis? Well, the enlarged liver and spleen, the yellow skin, the dark brown urine, okay, because it has the bilirubin in it, and low blood cell count could also fall under that. And then which are general anemia signs? General anemia signs are the signs that are common in all types of anemia, and that would be pallor, weakness, increased respiration and heart rate, and a low red blood cell count. Which type of deficiency is caused by pernicious anemia? This is due to a vitamin B12 deficiency. And tell whether the following statement is true or false. Patients with sickle cell anemia who also suffer from lung diseases are more prone to sickling. This is going to be true, right, because they're going to have decreased oxygen in their blood, and decreased oxygenation causes increased sickling. Okay, that's it for topic 4. We'll see you for topic 5.